Hello, everybody. I would like first to thank Manus for the kind invitation and congratulate him for the nice congress and the nice scientific program. I'll speak about partial rotator cuff ruptures, yes, but only past rotator cuff ruptures. First thing is to define what's the field, what we are going to speak about. And we consider the partial thickness tear a definitive disruption, not just a fraying of the tendon. And the degree of the lesion is mostly described in depth of the lesion and not in the extension of the lesion according to the tendon. And you can see various photos where you see partial rupture tears. We tend to classify it at home as elements, and we are going to speak only about articular side rotator cuff partial tears. So one of the things that we must have in consideration is the natural history. Because if we thought that the small and tiny lesion will heal, perhaps we'll leave it like that. But the natural history says that spontaneous heal is extremely rare, not impossible, but extremely rare. And the facts that are contributing for that is, of course, aging, the muscular contraction that is pulling the tendon, the hypovascularity that is in that environment, the inflammatory changes together with the oxidative stress, and this leads to augmented apoptosis and the degradation, progressive degradation of the quality of the tendon. One of the things that we know that is definitely interfering with tendon healing is, of course, smoking. The pathogenesis, you can see that in the video, you see a patient with scapular dyskinesia. And we have had 2 talks about the dyskinesia of the scapulae and the adaptive movements of the shoulder. So it always begins either with a traumatic event or a non-traumatic event. And so we'll have either an intrinsic factors conjoined with extrinsic factors that will lead to an abnormal cynetic movement of the shoulder and afterwards of the shoulder girdle. And then if we have a traumatic incident, of course, you'll have an impairment because of the structural lesion. But if you only have an imbalance of the shoulder, most likely you'll end up having a structural disease, as has been shown, for instance, for the posterior superior impingement. The clinical presentation is very variable. And as Ladislav said, there's no correlation between the MRI findings or even the arthroscopic findings somewhere and the clinical picture of the patient. This is due because most of the clinical picture of the patient is based on the inflammatory response and of the quality of the long head of the biceps or stability of the long head of the biceps. That's why there are so much variabilities. For imaging, we can use, of course, echographic exam, as you can see, because it's dynamic, and nowadays the new equipments are most likely to have the same specificity and sensibility as MRI, but for the time being, of course, the MRI is with or without contrast, is the gold standard for the diagnosis. In some countries, like in France, for instance, they tend to use arthro CT scan, but not in my practice. We could also have a diagnosis during surgery, because we didn't do a diagnosis, we were not able to compensate the patient, and we go to operate him, for instance, for an impingement syndrome to do a subacromial decompression, and we have the surprise, let's say, of a fraying of the tendon, and we have to deal with it. That's another way to do the diagnosis. So now we arrive to treatment. The goal, of course, is to achieve the cure. And if we, by conservative measures, are able to alleviate the symptoms and to give good function, there's no need for a surgery. Because if you get a balanced shoulder, you'll most likely won't have an aggravation of the structural damage. On the other hand, if you continue to have imbalanced shoulder and you continue to not being able to repair the lesion, then you have an imbalanced shoulder. While we were talking, there was running a video with a posterior superior impingement that I'm passing again, and just to see, for you to see the kissing lesion. But the idea that I want you to have is that the treatment of this pasta lesion is not the treatment of the lesion by itself. You should have to treat the micro instability of this patient in order to get rid of this problem for the patient. So we must be aware and correlate what we see with the history of the patient and the clinical exam of the patient, and of course of the activity of the patient. So the critical decision for us is to know where, when, and how to treat those patients. And if we are going to repair the patient because we don't have a balance of the patient, then we must decide if we treat it in situ or if we debride it all and transform it in a complete rotator cuff rupture in order to treat this patient. I'm going now to try to answer those questions and to answer the questions what to do with the long head of the biceps that we know it's a serious problem. So to treat, I advise you to have general principles. So mark any suspicion lesion on the articular side, and then you go to the bursal side in order to see, for instance, as in this case, if you have also a rupture on this side or a fraying on this side, most likely this seemed like a partial rotator cuff rupture, but it is a complete rotator cuff rupture. So it is important for you to debride all the bursa in order to completely see the bursa and in order to be able to use multiple portals in order to see the rotator cuff. Also, it is important to assess the stability and quality of the long head of the biceps in order to take a decision. In this patient, you see the anterior pulley is not too good, the posterior pulley is gone, so most likely, as you have seen, there's inflammatory signs of the long head of the biceps inside the groove, as you can see now. So you most likely have to take a decision about this long head of the biceps after you repair this tendon, because if not, you'll squeeze it, you'll change its balance inside the groove, and you need to do something. What should we do? We have two options. Either we do it intra-articularly, stenodesis, either we do it ex-articularly. We now are tending to do ex-articularly and ex-articularly with the screw, as you can see on the left side. And on the right side, you'll see an intra-articular solution for the long head of the biceps. So we tend to take some action on the long head of the biceps, and of course, in the sports environment, we tend to do it with a screw and extra-articular. Another option will be to do it sub-pectoral. We have done it before also, but as you know in the literature, there's no really statistical significant difference between one and the other. So we tend to do it ex-articular and with an interference screw. When we have degenerative partial rupture, so we don't have a single traumatic incident to begin the complaints, we don't transform the rupture in a complete, we transform the rupture in a complete one. Why? Because we think the rest of the tendon is not of good quality because this is a degenerative problem. We tend to do it and to solve it, looking from intra-articular to, and working from the subacromial space. We don't use metal anchors anymore, we use peak anchors. But it's the same. And I called your attention for the images on the right because we use a single needle in order to be very precise where we put our sutures, because I think the most important problem post-op for these patients is over-tightening of the rotator cuff, of tensioning of rotator cuff, and most of the cases of stiffness is on account of this. So we are very keen of not overstretching the rotator cuff in order to avoid some stiffness. So the result will be like that when we do the stitches or we do the knots on the subacromial space that are going to be now. But we'll move on. In traumatic partial ruptures, let's say traumatic incident, complaints after the traumatic incident, no balance with physiotherapy, they arrive to surgery. Normally they have that flap that you have seen there, and there's a difference between the traumatic one and the non-traumatic one. The ones traumatic, they have a flap, and this I tend to not complete the rupture because my tendon is of good quality. It was an incident, a traumatic incident, a single one that broke my tendon, so I'll tend to do the same. I use the same method, so we move on. But the things are not always like we like. And here we operated on a tiger. Just to explain to you, sometimes patients are not the way they should be for us to treat them. Very muscular and sometimes not very compliant with the things that we do. And sometimes, of course, we, with our techniques, do it complicated a little bit, and we have to solve those problems. So those techniques that I showed to you are not without some problems. So for my take-home message, I'd say that treat past the ruptures depending on the clinical and structural factors. If you are dealing with surgery, arthroscopy is the tool for past the ones because you cannot do the diagnosis. Otherwise, then I showed you general principles how to deal with the problem. What I do repair in situ traumatic tears, and I debride the rest of the tissue on the generative and transform it to complete rupture. And I always take, always is a big word, most likely take an action on the long head of the bicep, and I try to keep it simple. Thank you very much.